What I want you to do as we go through this case, take some mental notes of the things that were not done well or the things that were omitted altogether that led to this bad outcome. EMS call comes in, you've got a patient 2 minutes out. It's an elderly female, she's fallen and she's in a lot of pain. They're dosing with fentanyl right now for her pain. She's rolling through the door right now. You see this patient here, her left leg is obviously shortened. You're a good ER doctor, you go to feel a pulse in that foot, there's no pulse in the foot. This is an emergency, I need x-ray in here now. All right, this hip is out and I don't have a pulse. This is an emergency, I've got to get this reduced. No, there's no time for sedation. Nurse, can you hold the pelvis down, please? Ma'am, please stop screaming. Stop, I know this hurts, stop screaming. This is not gonna work. Can we get some midazolam, please? No, this is not a sedation. This is not a sedation. We're gonna do midazolam just for anxiolysis. Let's go ahead and give 4 milligrams of midazolam. All right, this is an emergency, we've got to go. Hold the pelvis, please, nurse. Man, please stop screaming. All right, let's give 4 more milligrams of midazolam. Let's give it a minute. Let's make sure it's working. Nope, this is not a sedation. This is not a sedation. All right, let's try again. There it went. Let's pull her out to length. She's not breathing. Oh, she's not on the monitor. There's no BVM in here. Okay, go get respiratory therapy, get a BVM. I'm gonna push in front of the mastoid, behind the mandible. This is the only good part of this case, actually, the Larson maneuver. If you don't know the Larson maneuver, look up the Larson maneuver. All right, great, you've got the BVM. Breath, breath. Great, please get her on the monitor. Breath, breath. Her SAT is 60. Breath, 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 breath. Great, she finally came up, but she's still apneic. I gave midazolam, that can last up to an hour. We're gonna have to intubate the patient. That was obviously worst case scenario. That is not based on an actual case. It is, again, just to demonstrate the things that can go wrong with sedation. Here's the take home of the entire talk. If you don't remember anything else, just remember this. With poor preparation and poor patient selection, all levels of sedation in the emergency department can be dangerous. All levels of sedation in the emergency department can be dangerous, including minimal sedation, anxiolysis. We all remember the very tragic case from a few years ago. Patient was getting MRI. Again, this is extreme. The doctor ordered some midazolam for anxiolysis, didn't order it, gave a verbal order. The trade name for midazolam starts with a V. Another drug that starts with a V was pulled. The patient was given vecuronium. They weren't on the monitor. Their nursing staff was stretched very thin. They couldn't adequately monitor the patient, and the patient died. Now, that's obviously an extreme, but all levels of sedation can be dangerous if you don't prepare and you don't choose the right patient. The flip side of that coin is all levels of sedation can safely be administered in the emergency department with proper preparation and proper patient selection. And you say, well, Steve, you have general anesthesia up here. I'm not an anesthesiologist. Yes, but what you have to remember is all these levels exist along a continuum. It is not uncommon during one sedation event to drift through multiple levels of sedation. Now, please don't enter sedation and say, hey, I'm gonna do general anesthesia for this patient. That's where I'm gonna get them and that's where I'm gonna keep them. That is not safe. But along this continuum, it is not uncommon to drift into general anesthesia, and that can be safely done in the emergency department. If you've ever done a painful procedure on a patient and they did not wake up, you have drifted into general anesthesia, and that's okay if you've prepared the right way and you've selected the proper patient. Now, the caveat to all this, there is another level of sedation called dissociative sedation, which is very unique. It's very unique to ketamine only, but again, it's another level that can be safely administered in the emergency department. I want to get into the meat and potatoes, so I'm not going to belabor this anymore. But if you are struggling in your hospital to get the privileges you need to properly care for your patient with sedation, you can point your phone at this QR code. This is an article from Annals of Emergency Medicine, phenomenal review of the safety of emergency medicine sedation, phenomenal review of all the supporting bodies supporting the safety of all levels of sedation in the ER. Again, this can safely be done with proper preparation and proper patient selection. Click, click, perfect. All All right, let's jump in the meat and potatoes. I cannot cover everything there is to cover with procedural sedation in the time allotted, so we're going to hit some high notes. These are the 3 things that I want to talk about today. The sedation medications, we're not going to cover them exhaustively. I want to mention a few points about each. Our monitors, how I set my monitor up and what monitors you need for your patient when you're performing a sedation event. And then finally, the morbidity of our patients that we are sedating, our patient selection. Starting with medications. In this case, we used midazolam. Midazolam is a phenomenal anxiolytic. We know midazolam, it's been around forever because it doesn't impair respirations, doesn't have as much effect on hemodynamics. Why did it have that effect in this case? First of all these drugs are unpredictable. But secondly, midazolam, benzodiazepines, when you combine them with an opioid, they have synergistic effects that can suppress respirations, that can cause hemodynamic instability. This patient was given fentanyl right before they rolled into our emergency department, and then we mixed that with midazolam. So be cognizant of what other drugs the patient has in the system. I love midazolam for anxiolysis. This is my go-to. Hey, the patient's freaking out in CT. Can we give something? Absolutely. Take a couple milligrams of midazolam over there. However, make sure the patient's on the monitor. Make sure someone is staying with them just in case something happens. But again, overall midazolam, 0.05 milligrams per kilogram. It's a phenomenal anxiolytic drug. This was the game changer for EM sedation. I feel like propofol's gotten a bad rap over the last few years, but it's a phenomenal drug. It's very quick on, very quick off, easy to titrate. Yes, it can lower blood pressure. Yes, it can impair respirations a little bit. What I'll say is if you have a patient that is so hemodynamically fragile that they cannot tolerate propofol, you probably should not be doing the sedation. That might be my phone, my apologies. I thought I turned it off. If they're so hemodynamically fragile that you cannot use propofol, you probably shouldn't be doing the sedation at all. Again, we know the dosing of propofol. You all know it. You use it quite a bit, 1 per kilo for your induction dose. Make sure you have everything ready. But propofol really is a great drug. It provides no analgesia. If they're hurting, treat their pain first. What I do if somebody comes in with severe orthopedic injury or something painful, I treat their pain up front with an opioid, and then I can use less propofol during the sedation. Etomidate is another one that I feel like has gotten a bad rap over the last few years. I do use etomidate primarily for cardioversion. Remember, etomidate can cause myoclonus, which can make it less favorable for orthopedic reduction. I do use it for cardioversion. The thing you need to remember about etomidate for cardioversion is if your patient is severely myoclonic, the defibrillator may pick that up as artifact, and you may have difficulty synchronizing with their QRS complexes. So make sure you're looking at your monitor, make sure that the sync is not picking up artifact, it's actually picking up the QRS complexes before you deliver that electricity. Etomidate has no analgesic properties. Treat pain if you're using etomidate. The first two I feel like have got a little bit of a bad rap in the literature over the last few years. I think that we've been giving ketamine too much of a pass in the last few years. I love ketamine. I'm an ER doctor. I love it as much as you do. Ketamine is not an excuse for poor preparation for sedation. Ketamine is not an excuse to sedate unstable patients. A couple of years ago, I gave a version of this lecture, and on the EM Docs Facebook group, I reached out and said, hey, I need some sedation stories. I want to make this case-based as much as possible. Who can tell me some sedation stories? I got a list of bad outcomes from sedations, and they all involved ketamine. I love ketamine. Typically, your patient will maintain their airway. Typically, it's relatively hemodynamically neutral. But ketamine is not an excuse for poor preparation and poor patient selection. Ketamine can make a patient lose their airway, especially if you push this fast. Ketamine can induce apnea. You need to be pushing it slow over at least a minute. Everybody's ready to go. And it feels like forever when you push this over a minute, but it needs to be pushed slow. In a hemodynamically fragile patient, ketamine can lower your blood pressure. Have them on full monitoring. Be prepared for the bad stuff that can happen. Especially in the airway literature, some retrospective studies have really shown us that we're getting sloppy when we use ketamine. Ketamine is not an excuse for poor preparation or poor patient selection. Ketamine does provide analgesia as well. Again, it's a great drug. I use a lot of ketamine, but you've got to still go through the preparation steps. And then this drug I hate. I actually do use some dexmedetomidine in my practice. I don't know who's doing the sedation research, but they're trying to force dexmedetomidine on us as a procedural sedation agent. It's a great drug. I use it in my emergency department, but when I read the literature and I read the pharmacokinetics of this drug, I don't think it's a great procedural sedation agent. It's a central alpha-2 agonist. It chills our patients out. However, it just chills them out. If you're doing something painful to them or something invasive, they will wake up. They will wake up on dexmedetomidine. It takes a while to kick in, so you're looking at about pushing it and then being able to start 30 to 60 minutes later. Difficult to titrate. A lot of times it requires a continuous infusion to maintain the patient where you want to maintain them. And then it hangs around a lot longer than some of our other agents. Being a central alpha-2 agonist, it will lower heart rate, it will lower blood pressure, and it's really just going to chill our patients out. It is popping up more and more in the literature, and some of the papers are showing it's equivalent to other drugs. It just takes a lot longer to recover patients. But in my mind, we have better drugs that we've known, we've used for longer. So when you hear about dexmedetomidine for procedural sedation, I'm not a fan of it. Here's when I am a fan of it and when I do use it. So you have a patient, acute decompensated heart failure, acute decompensated COPD. You need them on non-invasive ventilation. They keep ripping that mask off. I do think dexmedetomidine is a good option. They will keep breathing, right? They'll maintain their airway. They'll just chill out and hopefully allow us to resuscitate them with this non-invasive ventilation. And this is one of the times that I frequently use dexmedetomidine for sedation, but I'm using it in the anxiolysis. Now, ordinarily, if I'm doing anxiolysis, every time I push midazolam, I'm not putting them, I'm not putting them on end-tidal CO2. I'm not filling out all the paperwork. I don't have respiratory therapy there. In this situation, while this is anxiolysis, if I am giving anxiolysis so they can tolerate non-invasive ventilation, I do have everybody there. Matter of fact, I may have more stuff there. This paper did a really good job of reviewing the literature on anxiolysis for non-invasive ventilation. Dexmedetomidine was used, midazolam was used, analgesic dose ketamine was used. What they found was there was some success with this, but there's a very, very high failure rate. If you're having to provide anxiolysis to get them to tolerate non-invasive ventilation, there's a really good chance that you are going to progress to intubation. Be prepared for that, be in the room. And again, this is the time that I will use dexmedetomidine. So midazolam I can use for anxiolysis, dexmedetomidine I can use for anxiolysis. This is the perfect drug for anxiolysis. Inhaled nitrous oxide. My dentist has been giving me this for 30 years and I turned out all right. Like there's essentially no monitoring in the dental office when this is being given. This is a phenomenal drug, phenomenal safety profile. Throw the mask on them, let them breathe on it for a few seconds, you're ready to go. When you're done, pop it off, flush them out with some oxygen, they're ready to go home. Very, very safe. There is some upfront costs. You gotta have the equipment to deliver it. You also have to have something scrubbing the excess from the air so that we don't get drunk on it. There is a lot of reported abuse. Everybody's sitting back there taking a hit of NOS. But it's a phenomenal agent. Here's what is limiting it from being in more of our emergency departments. US of A, baby. It's all about the dollars. This is very difficult to bill for. So while it's great for our patients, it's very, very difficult to bill for. So it's hard to sell to admin. Hey, I need this upfront cost to deliver nitrous oxide in my ER, be able to scrub it, and then we need to keep an ongoing supply of it. And oh, by the way, it's not gonna bring any extra money. This is showing up in more and more of our emergency departments. If you have the opportunity, advocate for this in your ED because it's really a phenomenal drug for anxiolysis in our emergency department, but it's difficult to get. Talked about the individual agents. Let's quickly talk about cocktails. This is our favorite cocktail we've used forever, the ketofol. The literature is mixed on ketofol. The POKER trial, which was a blinded randomized control trial of this, we didn't know what we were pushing, failed to show any benefit. However, retrospective data and unblinded studies have shown some benefit with this. And that makes sense to me because we're smart. We went to school for a long time. We know how these drugs work. You can tailor this to your patient and you can improve your outcomes, you can reduce your adverse events. Please don't give this blindly. If you're doing Ketofol, please don't say, okay, 0.5 per kilo of this one, 0.5 per kilo of this one. All right, I'm gonna redose 0.25 per kilo of each. Be mindful about what you're giving. So what I do is I start my sedations off heavy on ketamine. I may give that full 1 per kilo of ketamine, and then I finish setting everything up, make sure everything's ready to go, and then when I get to the painful part, or the part I need them really relaxed, then I'll give some small doses of propofol to get them through that. And then when I finish my sedations, when I'm using ketamine and propofol mixed together, I will actually give some microdoses. So like 0.1, 0.2 per kilo of propofol, just as I'm finishing them off to try to prevent that emergence reaction. Your doctors, your phenomenal ER physicians, you know how ketamine works, you know how propofol works. I do like this cocktail a lot, but be mindful about it. Know what your desired outcome is and use the drugs to get to that outcome. And there's this guy again. Researchers really want to make this guy a procedural sedation agent, and so they're doing the Ketadex. Ketadex, the first paper on this came out a few years ago in the GI suite. More papers have come out, the pediatric literature, using these intranasally to try to get to your sedation. The papers are showing that it's non-inferior. Well, I'm going to stick with the drugs that I know and I've used for a longer amount of time. However, if you're really familiar with dexmedetomidine, if you use it in your ED a lot, you've done research on it, you're comfortable, yeah, outcomes seem to be the same. But I'm not there yet. I think we have better options. But when you read about it, you heard about it here too. We've hit medications. Next, let's talk about how I set up my monitor for sedation. So the first thing, any residents in here, you have been spoiled. At most teaching hospitals, you have phenomenal nurses who will set your monitor up for you. The blood pressure needs to cycle at least every 3 minutes. You are responsible for making sure that this is set. It's really easy to do. You select the blood pressure, you go to blood pressure auto, and then you can set how often it's cycling. You are responsible for making sure that's at least cycling every 3 minutes. You want to get telemetry on the patient, and then for your pulse oximeter, you want tonal feedback on your pulse oximeter. So if you go select SpO2, and then you come over here to where it says rate volume, and you select that, it's going to allow you to turn tonal feedback on your pulse oximeter. So if the patient desats, you get that deet, 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 deet. When our ADHD kicks in and we're not watching the monitor, we can hear that, and it immediately gets your attention. I bet you at least half of you are thinking, well, my monitors can't do that. I bet you they can. Every ER I worked in, I turned this on and it works on my monitors. I intentionally chose this old dinosaur crummy monitor to demonstrate it on here because it even works on this one. It probably works on your monitor, just nobody knows how to turn it on. But turn this tonal feedback on. When you select this, you're gonna have percentages to choose from on how loud you want that. I typically set it high, 70 to 80, so I get that tonal feedback. So I get very early notification if my patient's desaturating. Set my blood pressure, set my telemetry, I'm setting my pulse oximeter, and then we've got this guy, your end-tidal CO2. Most adverse events that happen in sedations can be predicted earlier or prevented altogether with the use of waveform end-tidal CO2. And I say waveform end-tidal CO2, the waveform is important. Just to review, as I exhale, I'm going to start to get this peak on my waveform. As I continue to exhale, I'm going to get this plateau. My reading is going to be the very highest peak that reached on this plateau. That's going to be my end-tidal CO2 reading. And then as I inhale, as I breathe in again, that's going to bring me back down to this baseline of 0. So the left side is representing inhalation, that right swoop down, and the bottom is going to represent inhalation. And during a sedation event, if your patient's oversedated and they're breathing too slowly, you may see this, longer exhalations with a much higher end-tidal CO2 value. This is how it would look on an actual patient. You can see this exhalation is taking forever, and my end-tidal CO2 value is rising. Now, you can follow just the number. As a rule, get a baseline on your patient. If it's going up a lot or down a lot from your baseline, you probably have an issue, but seeing the waveform is going to help you diagnose the issue. This one, they're just breathing too slowly. You need to let them wake up a little bit, let them breathe a little bit faster to adequately get rid of that CO2. Another thing you may see is you may see a relatively normal waveform and then a bunch of these short, inconsistent, small breaths with highly variable end-tidal CO2 or even very low end-tidal CO2 readings. This is also not great. This is indicative of a patient who's losing control of their airway. So if you looked at this patient clinically and looked at their breathing, they'd probably be doing something like and what's going on is they're not able to fully exhale, so you're not getting that end alveolar CO2. This patient probably needs that Larsen maneuver, right? They need their airway opened. They may need an MPA and OPA and then allowed to wake up a little bit more. End-tidal CO2 can give us a lot of information about pathology. So when I look at this left side, this represents exhalation, and when I look at this angle, this alpha angle, it gives me a lot of information on how the patient is exhaling. If this angle starts to widen, that tells me that my patient's having trouble exhaling. If it takes on this shark fin appearance, this is pretty classic for reactive airway disease. If you see this before you start, bust out your trusty stethoscope, listen to the lungs. Are they wheezing? Are they having a bronchospasm? If so, I probably don't need to sedate them. If you see this during the sedation event, it can give you early warning that your patient is starting to have a bronchospasm. And then we know this right side of this represents inhalation. If you see this angle widening out, a couple of things can be happening. First of all, most commonly during a sedation, when you see this angle widening, nothing is wrong. Everything's gravy. It's just because I have oxygen coming through the detector, it's washing out some of the CO2, and it's going to cause that slurring. That's why it's so important to put your patient on this while they're awake, so you can see what their normal looks like. And again, as the oxygen's coming through, it can be washing off CO2 off of the detector, and it can get you slurring of this right side of the waveform. However, during a sedation event, if you see both of these angles start to widen out, and you get an appearance like this where both of the angles are widening, this is gonna be your first indication of laryngospasm. Before the patient desaturates, before the chest stops rising, while they're still moving air, this is your earliest warning of laryngospasm. And if you see this, prepare for it. Get a BVM ready. Go ahead and perform the Larsen maneuver. That can fix the laryngospasm in many patients. Laryngospasm is pretty terrifying when it happens, but it doesn't happen often. We think of this as something that happens with ketamine. A great paper that came out in the pediatric literature that looked at like 250,000 sedations showed that it's not unique to ketamine, especially in our pediatric patients. Matter of fact, the highest incidence of this was with Ketafol, and propofol had a very high incidence of laryngospasm. Utilizing end-tidal CO2 is going to give you your earliest possible warning that your patient may be having a laryngospasm. So we've talked about the medications we've used. Little pearls about each medication. I didn't exhaustively review them. If there's any of these meds that you don't know well, go read the dosages duration. We've talked about the monitors. We're going to get them on the blood pressure monitor. We're going to have that auto cycling every 3 minutes. We talked about pulse oximetry, turning the tonal feedback on. Do that on every sedation. I actually do it on every intubation as well. Let's talk about the morbidity of our patients. Let's go back to the case we started with. What medical history did this patient have? We have no clue. What other injuries did this patient have? Did she have bruising on the chest and the abdomen? Did she have other injuries that were making her unstable? We have no clue. What did her vital signs look like? Well, maybe we got EMS vitals. Do we have her on the monitor here? If you put her on the monitor and saw these vitals, you would never start a sedation with these vital signs, with very, very rare exception. We need proper patient selection before you sedate. Look at their medical history. Do a good exam on the patient. Look at their airway. Look for other injuries. Look for things that could hinder breathing during sedation. And if it's not safe, if it's an ASA 3 patient, consider whether this needs to be done. If it's an ASA 4 patient, if there's a life threat going on at that point, you really need to consider sending this patient to the operating room to be sedated there. All levels of sedation can be safely administered in the emergency department with proper preparation and proper patient selection. All levels can be safe, but there is a flip side to that coin. With poor patient selection, and poor preparation, all levels of sedation can be dangerous. Thank you for your time.
Dr. Haywood, if you wouldn't mind sticking around, do we have any questions from the audience?
Sorry.
You're not allowed to leave yet.
I know, man. I was ready to bolt. I'm going to get the rest of my coffee that's back there.
I have a feeling how you're going to respond to this, but if I'm using ketamine IM, do I still have to do all that setup and stuff? Is that more safe in your opinion?
So it depends on your hospital. So first of all, if your nurses are insisting that you set up all your stuff, because really you're risking getting them in trouble. So I, at minimum, expect them to be on a monitor and a pulse oximeter. Now that's going to may last for an hour plus, especially when I'm dosing at 5 per kilo. And so I'm not going to be there at the bedside for an hour. I'm a realistic EM physician, but I do minimum want them on pulse oximeter, I want them on tele, I want them on blood pressure. So the times I typically do IM ketamine most frequently is guys my size that are freaking out, that are in excited delirium, and I know benzos is first line for that, but I need to quickly assure the safety of my staff and assure the safety of this patient. On those patients, I'm hitting them at like 5 per kilo, and when they're my size, that can be like 500-600 milligrams of ketamine, and that's gonna last about an hour. So what I do is I hit them with that. As soon as they go out, I'm having the nursing put them on the monitor, and if they're in my psych room, my lockdown room, I'm so sorry, we'll have to move them to a regular room to minimum have them on pulse oximetry, blood pressure, and telemetry. And then when they start to come around, especially excited delirium, I need to start treating the excited delirium. So as they're starting to come back to, then I'm doing benzodiazepines or antipsychotics as needed, and I want them on the monitor when that's done. But if your nurses are insisting that all the paperwork be done and everything, absolutely do it. Go ahead, you got to follow up?
Sorry, would you also recommend having an IV then in these people? And my question point is like, when you do some pediatric sedations,
oh yeah,
some hospitals different, and like the nurse is like, well, you need to have an IV. I'm like, why? Ketamine's so safe. I am.
Yeah, and you know, for those, especially kids, what I'll do a lot of times is I'll do intranasal ketamine, because then I don't have to stick them at all, and do intranasal ketamine. And in my shop, I can get away with not doing an IV. Hospital policies have a great way of appearing when nurses disagree with you, but if the nurse ever tells me, well, hospital policy says I've got to have an IV for this patient, great, follow hospital policy, and then after this event, I'll address it again. Did that answer your question? Okay, cool. Any other questions?
Any additional questions?
I have one more question for you. So
Yeah, shoot.
What about the really good liver patient who's just chewing through your propofol and you can't get them down? Do you just keep updosing a single agent, or do you consider switching and adding in a second agent?
Yeah, I do a lot of ketofol, and so on that patient, I absolutely am throwing more ketamine in the mix, and I may abandon propofol altogether. I ask patients I've found anecdotally that my heavy drinkers, my alcoholics, will chew through the propofol, and those are the ones that I'm starting heavy with ketamine. I'm gonna go ahead, I'm gonna do a full sedation dose of ketamine, 1 per kilo, and then I might try a little propofol if I need them to relax a little bit more. But yeah, they chew through it, and I think it's kind of pointless to be pushing 20 mLs of propofol and still have the patient yelling at you.